Before you do anything else, press your thumb firmly against one of your fingernails and hold it for 2 seconds. Watch the nail bed go white, then release and count the seconds until the pink comes back. Under 2 seconds is normal. 3 seconds or more, repeated across multiple fingers, is a signal that cardiovascular medicine takes seriously every single day. I am Dr. Arthur White. My career has been built around preventative cardiovascular care for adults over 60, and this test, free, equipment-free, performable in any room, is used in cardiology clinics and emergency wards worldwide as a rapid indicator of how well the heart is circulating blood. Most people over 60 have never been told how to read what it shows. Stay with me. The last condition I cover is the one that surprises almost everyone. Your fingertip is connected to your heart by the longest, thinnest thread in your entire circulatory system. The capillaries beneath your fingernail are among the smallest blood vessels in the human body. They sit at the absolute periphery of your circulation, at the far end of the line, and because of that position, they are among the first structures to feel any change in what your heart is doing. When cardiac output drops, even slightly, the fingertip capillaries register it before almost anything else does. That is not a coincidence, it is anatomy, and it is the entire reason this test works. The capillary refill test has been used at hospital bedsides for decades. It requires no machine, no lab, no appointment. What it measures is reperfusion speed, how quickly the smallest blood vessels in the fingertip recover from externally applied pressure. That recovery speed is a direct reflection of how efficiently your heart is moving blood outward to the body's most distant tissues. When the heart is doing its job well, recovery is fast. When something is interfering with cardiac output or peripheral delivery, recovery slows. Not gradually, not ambiguously, measurably. In seconds, you can count yourself. To understand why this matters more after 60, you need to understand one thing about how the aging cardiovascular system handles early dysfunction. In your 30s and 40s, your heart has considerable reserve. If one part of the system begins to struggle, other mechanisms compensate quietly. Heart rate adjusts, vessels dilate, the body finds a workaround, and nothing visible happens for a long time. After 60, those reserves are thinner. The buffer narrows. Problems that would have hidden for years in a younger body begin to surface earlier. They surface first at the periphery, at the fingertip. In the 2 seconds after you release the pressure, this test is used in every emergency room and intensive care unit in the world. The research supporting it goes back decades and has only grown stronger. And yet the overwhelming majority of adults over 60, the people with the most to gain from knowing how to use it, have never been shown how to perform it correctly or told what a slow result might mean. Not because the information is complicated, not because it requires a medical degree to understand, because a standard 15-minute appointment cannot cover everything. And a simple bedside test rarely makes the priority list unless something is already visibly alarming. That gap is exactly what I want to close for you today. Before you can interpret what this test tells you, you need to perform it correctly. An incorrect technique produces a false result, and a false result is worse than no result at all. It either misses something real or creates a worry that does not exist. The correct method is specific, but every step takes less than a minute to learn. Sit in a warm room. This is not optional. Cold temperature causes peripheral vasoconstriction. The small vessels near your skin narrow to preserve core body heat, and that constriction will slow capillary refill regardless of what your heart is doing. If your hands feel cool, sit quietly for 5 minutes in a warm space before you begin. Remove nail polish from at least the index finger and middle finger of each hand. The test depends entirely on watching a color change in the nail bed, and any opaque coating makes that change invisible. Hold both hands' palms upward at the level of your heart, not above it, not resting in your lap. Position matters because gravity affects capillary pressure directly. Heart level is the only position that produces an accurate reading. Press the center of your index fingernail firmly with the thumb of your opposite hand. firmly enough that the nail bed blanches visibly to white. Hold for exactly 2 seconds. Count it, do not estimate. Then release completely and immediately count the seconds until the full pink color returns across the entire nail bed. Under 2 seconds is normal. 2 seconds exactly sits at the boundary. 3 seconds or longer is the threshold that clinical medicine considers meaningful. But here is the rule most people miss. One finger is not enough. A single slow result on one finger could reflect a local cause, a minor injury, a compressed nerve, a position artifact, not a systemic condition. What you are looking for is a pattern. Test the index finger and middle finger of each hand in sequence. If 3 or more of those 4 fingers produce a consistent refill time of 3 seconds or longer in a warm room with your hands at heart level, that is your cardiovascular system speaking through your fingertips. That is not a local finding, that is a systemic one. I also want to say something about repetition, because it is the step most people skip. The conditions that produce a prolonged refill time in adults over 60 are not always active at the same moment. Some are intermittent. Some fluctuate day to day. A single normal result does not close the question. A single slow result does not confirm a diagnosis. What carries clinical weight is a pattern that reproduces consistently across multiple testing days under the same controlled conditions. Test more than once. Record what you find each time. Your memory is not a reliable baseline over weeks and months. A written result is. 5 specific conditions disproportionately affect adults over 60 and produce a prolonged capillary refill time before almost any other observable sign appears. Each one does it through a different mechanism. Each one can be silently present for months or years before a person feels anything they would call alarming. And each one, when caught at the stage where a fingertip test is the loudest available signal, is still manageable. The difference between catching them here and catching them later is often the difference between treatment and crisis. The first one ends up in my clinic more often than almost anything else I see. The heart's left ventricle has one essential job: contract with enough force to push oxygenated blood out through the aorta and into the body's full circulatory circuit. The measure of how well it does that job is called the ejection fraction, the percentage of blood inside the ventricle that actually gets pushed out with each beat. In a healthy adult, that number sits between 55 and 70%. When the left ventricle begins to lose its contractile strength, that percentage falls. And when it falls far enough, the condition has a name: heart failure with reduced ejection fraction. Not a future risk, not a statistical abstraction. A condition that develops slowly, silently, and, in its early stages, without a single symptom the person living with it would necessarily notice. The body's response to falling cardiac output is automatic and immediate. It begins redirecting what circulation remains toward the organs it considers non-negotiable: the brain, the kidneys, the liver. Blood flow to the periphery, the arms, the hands, the fingers, is quietly reduced. The fingers sit at the far end of the circulatory circuit, and they are the first to feel the rationing. The capillary beds beneath the fingernails receive progressively less blood per unit time as the ejection fraction falls, and the refill time after pressure lengthens in direct proportion to that reduction. Not approximately, not eventually, in direct proportion. Research from the European Society of Cardiology has confirmed that a capillary refill time above 3 seconds in a resting, warm adult correlates with ejection fractions below 40%, a level of dysfunction qualifying as moderate to severe heart failure, with sensitivity sufficient to serve as a screening indicator when imaging is unavailable. In 2020, a randomized controlled trial published in the New England Journal of Medicine, the Andromeda Shock Trial, studied more than 400 patients and found that treatment guided by capillary refill time produced outcomes equivalent to or better than treatment guided by lactate levels, a standard hemodynamic marker requiring a blood test. That is not a minor footnote in cardiovascular research. It is the elevation of a fingertip observation to a validated hemodynamic endpoint. A patient I will call Gerald came to see me when he was 73. He had no alarming complaints. He felt reasonably well, though he had noticed over the previous several months that he tired more easily than before. Climbing stairs required a pause at the top that had not been necessary a year earlier. He attributed it to age. During the examination, I asked him to perform the refill test while I observed. His index finger took just over 4 seconds to return to full color. 3 other fingers across both hands produced consistent results. I ordered an echocardiogram. It revealed an ejection fraction of 37%. Heart failure with reduced ejection fraction, developing quietly for an estimated 18 months. Gerald is doing well today. He received the right treatment at the right time. His fingertips were the first place his body had been asking for help. The second condition is one that millions of adults over 60 carry without ever receiving a diagnosis, sometimes for years. Atrial fibrillation, AFib, is an arrhythmia in which the upper chambers of the heart fire chaotically at 300 to 600 electrical impulses per minute rather than the orderly 60 to 100 of a normal sinus rhythm. The ventricles respond with an irregular rhythm that varies in both rate and in the interval between beats. That interval matters enormously. The ventricle needs a brief filling period before each contraction to generate adequate stroke volume. When those intervals are shortened and irregular, as they are during AFib, many beats eject significantly less blood than a normal sinus rhythm beat. The aggregate result is a reduction in mean cardiac output of 15 to 25%. Even when blood pressure remains within normal limits and the patient feels nothing dramatic, that reduction is large enough to produce measurably prolonged capillary refill at the fingertip. A 2018 study in the Journal of Cardiovascular Electrophysiology documented capillary refill time was significantly prolonged during active AFib episodes compared to matched sinus rhythm measurements in the same patients, and that refill normalization correlated with successful cardioversion back to normal rhythm. The test was tracking the cardiac output consequence of the arrhythmia in real time, at the fingertip, without any equipment at all. Here is the implication that I consider one of the most important points in this entire conversation. An adult with undiagnosed intermittent AFib who tests on a day when the arrhythmia happens to be active will produce a consistently slow result across all fingers. On a day when the heart happens to be in normal sinus rhythm, the result may look entirely normal. A single normal result does not close the question. If you perform this test and get a borderline finding, 2.5 to 3 seconds, not dramatically slow, but not clearly normal, repeat it on 3 or 4 separate days before drawing any conclusion. A result that reproduces consistently across multiple days and multiple fingers is the finding that carries weight. A result that appears once and disappears is a reason to keep watching. A patient I will call Miriam was 67 when she came in for a routine visit. No palpitations, no chest discomfort, no shortness of breath. She mentioned, almost as an afterthought near the end of the appointment, that she had been feeling intermittently fatigued for the past few months, mostly in the afternoons, nothing she could point to clearly. I asked her to perform the refill test while I watched. 4 fingers across both hands produced results between 3 and 4 seconds. I ordered a 14-day cardiac monitor. It captured 11 episodes of paroxysmal atrial fibrillation over the monitoring period. She had felt none of them. She was placed on appropriate anticoagulation and rate control. Her refill time, rechecked 6 weeks later, had returned to under 2 seconds. Her fingertips had been carrying the signal on the day I happened to be watching. If this has been useful so far, I want to ask you to do one thing before we go further. Hit the like button. It takes 1 second, and it genuinely determines whether this information reaches someone else who needs it. Stay with me, because the next 3 conditions are the ones most people do not see coming, and the final one carries a clinical implication that I believe will change how you think about a diagnosis you may already have. The third condition connects this test to a disease process most people associate with leg pain and walking difficulty, not with our cardiovascular risk measured at the fingertip. Peripheral artery disease, PAD, narrows the arteries supplying blood to the arms and legs through the same atherosclerotic process that narrows the coronary arteries feeding the heart, not a separate disease. The same disease operating in a different location. As the arteries delivering blood to the hand and finger capillaries narrow, the pressure driving blood through those capillaries decreases. Less pressure means slower refill after blanching. In early PAD, this prolongation at the fingertip may be detectable before the ankle brachial index. The standard clinical diagnostic test has fallen to the diagnostic threshold. The fingertip announces the problem before the standard test confirms it. The REACH registry, the largest international outpatient cardiovascular registry ever assembled, enrolling more than 67,000 patients across 44 countries, confirmed that peripheral circulation compromise is a reliable proxy for coronary and cerebrovascular atherosclerotic burden. The same disease narrowing the arteries in the arm is operating simultaneously in the arteries feeding the heart and the brain. A patient I will call Raymond came to see me at 69. No cardiac complaints. He had noticed his hands felt cool more often than they used to, but he had not connected that observation to anything medical. His refill time across both hands was consistently between 4 and 5 seconds. Vascular imaging confirmed early bilateral upper extremity PAD. A subsequent cardiac workup revealed significant coronary atherosclerosis that had produced no symptoms yet. 2 conditions, 1 fingertip signal, both still manageable at the moment we found them. The 4th condition approaches this test from a direction that surprises most people, because it is not primarily a disease of the heart or the blood vessels. It is a disease of the blood itself. Anemia, a reduction in the concentration of hemoglobin in the bloodstream, does not slow capillary refill by narrowing arteries or weakening the heart's contractile force. It slows it by reducing the oxygen-carrying capacity of every unit of blood that arrives at the fingertip. The capillaries refill with fluid, but that fluid is carrying less oxygen than it should, not slightly less, measurably less, and the body recognizes that deficit immediately. The automatic response is to increase heart rate and cardiac output, push more blood volume per minute through the circulation to compensate for the reduced oxygen content of each individual unit. In a younger adult with a healthy heart and full cardiac reserve, that compensation is sustainable. The heart works harder, the tissues receive adequate oxygen, and nothing visible happens for a considerable time. In an adult over 60 with any degree of underlying cardiac dysfunction, even dysfunction that has not yet produced symptoms, the sustained demand for elevated output accelerates decompensation. The heart that was quietly managing a mild efficiency reduction can no longer manage that reduction plus the additional workload anemia imposes. Cardiac output begins to fall. Peripheral delivery diminishes. The refill time lengthens. The fingertip is now reflecting the combined burden of 2 conditions that together produce a perfusion deficit that neither would produce alone to the same degree. A 2021 study published in the journal Heart confirmed exactly this pattern. Anemia in adults with established heart failure was independently associated with worse functional capacity, higher hospitalization rates, and significantly elevated cardiovascular mortality. The combination produced peripheral perfusion deficits, measurable by capillary refill time, that exceeded what either condition generated in isolation. That is not a minor statistical footnote. It is a direct statement about what can be happening silently at the fingertip of an older adult who appears, by every casual measure, to be doing reasonably well. A patient I will call Eleanor came to see me at 71. She was active. She cooked her own meals and walked her neighborhood most mornings. She felt, by her own description, reasonably fine. Only a persistent low-grade tiredness she had assumed was simply what getting older felt like. During a routine visit, I asked her to perform the refill test. 3 of 4 fingers produced a result of just over 3 seconds. A complete blood count revealed hemoglobin well below the normal threshold for her age. A cardiovascular workup confirmed early heart failure with mildly reduced ejection fraction. Neither finding had been dramatic enough on its own to produce a symptom she would have called alarming. Together, they had been quietly compounding at her fingertips for months. Both conditions were treated. Her refill time, rechecked 8 weeks later, had returned to the normal range. Her nails had been asking for help long before she thought to ask herself. The fifth condition is the one I mentioned at the beginning, the one that consistently surprises people when they hear it, because most who live with it have been told to think of it primarily as a blood sugar problem. Diabetes is a vascular disease. That framing is not an exaggeration. Chronic elevated blood glucose damages the walls of small blood vessels throughout the body through a process called advanced glycation, end product accumulation. Over years of exposure, this process stiffens vessel walls, narrows their lumens, and impairs the vasoactive responses that allow capillaries to dilate rapidly in response to local oxygen demand. In adults with long-standing diabetes, particularly those with years of suboptimal glycemic control, the capillary bed of the fingertip undergoes structural changes that directly slow refill time independent of cardiac output. The architecture of the vessels themselves has been altered, not temporarily, structurally. This creates a clinical implication I consider essential for any diabetic adult over 60 to understand. A prolonged capillary refill time in the setting of diabetes should never be dismissed as an expected side effect and left unexamined. The same microvascular disease that has structurally altered the fingertip capillaries is operating simultaneously in the coronary microvasculature, the renal vasculature, and the cerebrovascular circulation. It does not confine itself to the hand. A 2019 review published in Diabetes Care confirmed that microvascular dysfunction in the peripheral capillaries, detectable through capillary refill time, correlates with the severity of coronary microvascular disease in diabetic patients. The fingertip in a diabetic adult is a potential window into cardiac perfusion status that requires no imaging and no appointment to access. A patient I will call Vincent came to see me at 74. He had carried a type 2 diabetes diagnosis for 11 years. His endocrinologist was managing his glucose, and by his account, things were reasonably controlled. He had not seen a cardiologist. During a visit for an unrelated matter, I asked him to perform the refill test. 5 seconds on the index finger, 4.5 on the middle finger. Consistent results on the opposite hand. Subsequent imaging revealed significant coronary microvascular disease. His peripheral capillary findings and his coronary findings were two expressions of the same underlying pathology. He had been carrying both for years. His diabetes, understood as the vascular disease it is, had been writing the same message on every small vessel in his body, including the ones visible beneath his fingernails. He almost did not mention the fatigue he had been feeling. He had assumed it was age. 5 conditions, 1 test, no equipment. The same 2-second count, repeated correctly across multiple fingers on both hands, in a warm room with your hands at heart level, can surface a signal from any one of them before almost any other observable sign appears. But a result you can trust requires preparation you actually follow. Sit in a warm room for at least 5 minutes before you begin. This is the single most important step and the most frequently skipped. Remove nail polish from at least the index finger and middle finger of each hand. Hold both hands, palms upward at the level of your heart for 30 seconds before you start. Test at least 4 fingers, the index and middle finger of each hand, in sequence, not just one. Press firmly for exactly 2 seconds each time. Count honestly. Write the result down for each finger. Do not rely on memory. A photograph of your hands taken today in good natural daylight gives you something concrete and honest to compare against 6 months from now. Human memory is not a reliable baseline over that kind of time, and these changes are slow enough that they can become the new normal before you realize anything has shifted. Here is how to act on what you find. 1 borderline result on a single day, 2.5 to 3 seconds, is a reason to repeat the test on several separate days, not a reason to call your doctor immediately. A result that reproduces consistently across 3 or more fingers on both hands over multiple testing days is a reason to mention it at your next routine appointment. Describe exactly what you observed, the room conditions, the hand position, which fingers you tested, the specific times you recorded. 2 or more fingers producing a consistent result of 3 seconds or longer across multiple days is a reason not to wait for your annual checkup. Call your doctor's office this week. Describe the pattern you have documented. Ask whether a